My name's John Prowle. I'm chair of the ESICM AKI section, and I'm joined by Bairbre McNicholas, who's an intensivist and nephrologist from Galway in Ireland. And we're going to talk to you a little bit on World Kidney Day about why kidneys are important in the ICU and the background to World Kidney Day itself. So Barbara's going to quiz me with a few questions. I'm going to share my thoughts with you. She'll share her thoughts with you as well. And then we're going to talk to you just very briefly to flag up some of the educational opportunities that the section's offering in the near future.
So thank you, John. And my first question is, how frequently do people have kidney problems when they're in an intensive care unit setting?
Okay, well, that's a good question. So I think overt kidney problems can be present in between 30 and 50% of patients, depending on the kind of case mix you have. Certainly in terms of sepsis, up to 50% of patients are affected. The number of patients who receive renal replacement therapy is rather less than that, but it can certainly be up to 1 in 5 patients with acute kidney injury. But the other observation I make is that many patients in the intensive care unit may have problems with their kidneys without it being absolutely obvious, and therefore we should be concerned about the kidney health of all the patients in ICU.
Why is it so difficult to detect kidney problems in some patients in the ICU?
Well, I think there are a number of reasons. First of all, we don't know what their prior level of kidney function has been. I have particular interest in creatinine, which is our go-to marker. And in the kidney realm, we certainly have a biochemical marker that you don't have when you're interested in brain function or lung function, but it is imprecise because it takes time for creatinine to rise, and because other factors like metabolic changes affecting creatinine production can offset the rise in creatinine and mask the appearance and severity of acute kidney injury.
What are the implications for a patient who develops kidney problems? Are they as bad for somebody who is on dialysis as somebody who just develops a little bit of kidney dysfunction?
Well, I think that's an interesting question. I'd be interested in your thoughts on this. Clearly, dialysis is associated with significant risk of death, not just in the ICU, but in the year after ICU discharge in those that recover. There is a significant rate of death, particularly in those over the age of 65. Clearly, with lesser degrees of kidney dysfunction, it implies lesser levels of organ function, although some patients unfortunately die before we're able to quite ascertain the severity of kidney dysfunction. And there's to some extent, the kidney is a very sensitive marker of overall multi-organ failure, and is the sort of canary in the coal mine, and to some extent is a direct participant in multi-organ failure and organ crosstalk. So I think everybody's affected. It's a spectrum. Personally, I rather dislike the actual graduations of AKI classes because they're just punctuations that we use perhaps to organize epidemiological data. Our patients' care has got to be individualized, and any evidence of kidney dysfunction is clearly a marker of illness severity and could be a player in their outcome.
I completely agree with you there, John. I think, what would you think are the most important problems that people run into when they have AKI? My experience is sepsis, but I'd be curious to see what your thoughts are.
Well, this is a good, I think that there is, sepsis is one of the major risk factors for development of AKI in the ICU. On the other hand, patients who develop AKI are also at risk of sepsis. If they've come in having had cardiac surgery to develop AKI, they have immune dysregulation, they have fluid overload, they have persistent multi-organ failure, they may have a tendency to immune inflammatory dysregulation that puts them at risk of sepsis. So there are many complications and things that we have to worry about. But I think the theme of World Kidney Day, which we're kind of alluding to, has been a lot about kidney health. And we often have a focus on kidney dysfunction, but actually we should also be thinking about what our the kidney health of our patient is before they come into ICU, their risk, particularly if they're having elective procedures, what their kidney health is after ICU, and what we can do to improve their long-term outcomes as well, put them in pathways where that can be flagged up.
And so what are your thoughts on us trying to follow up patients who ran into kidney problems while they're in the ICU? Do you think it's more difficult in our critical care population? And what do you think we can do to make that a little better?
Well, I think this is a real challenge, and it's interesting. We polled some intensivists recently, and some of them felt that these people were very interested in acute kidney injury. That's not necessarily our job. Others felt that it was very much our job. I think one of the other problems is nephrologists are, and we both have a background in nephrology, are consumed with the management of the epidemic of chronic kidney disease, and they may find that it's difficult to follow up patients who may be at risk of chronic kidney disease in the future. But on the other hand, we're intensive. We can't be out there providing primary care. I think what we've got to do is have better ways to diagnose kidney health in patients recovering from ICU, and then to flag people for appropriate pathways, which may be in primary care, because there are so many interventions now for patients with or at risk of CKD that we didn't have before, that have proven benefits in terms of progression of CKD and survival. And it's a great shame if we expend huge amounts of financial and human resources to get somebody over a critical illness and neglect relatively small investment in their long-term health afterwards.
I couldn't agree with you more. And I think another focus is making sure that when people recover from their kidneys, that their quality of life is, we look at as much as a number telling us what's going on with their kidney dysfunction. Let me see if there are any more questions I can ask you. If you had one test that you could use to try and tell us what's going on with somebody's kidneys in the ICU, what would it be? Would it be based on data? Would it be based on laboratory measures? Or what do you think we need to do to try and get a better idea of what people's underlying kidney function is like?
Well, this is interesting because obviously kidney function is a little bit multidimensional. There's the level of injury the organ's had, and there's the actual function it's had. And the same is true with the heart. The heart can have poor function for a number of reasons that may recover, but it also may have had a significant degree of myocardial injury, but actually still functioning quite well at that point. And we have to understand those two different aspects, and there may be tests that we can enable us to do that, but we're still so bad at understanding the function in our patients, and that enables us to plan other aspects of their treatment. And so a better test of function in the ICU that gave us a more precise view on how the kidneys performing at that particular moment would be very valuable, and it'd be very valuable at telling us about kidney recovery in that patient and flagging up those patients who also may need some further attention to them throughout their recovery pathway. And there's methods of measured GFR in the pipeline. There are other biomarkers that may better reflect GFR in the context of critical illness and more rapidly. But they're not yet into clinical practice, and the problem is then operationalizing those with day to day. Because, for instance, if we measured kidney function more precisely and that then suddenly we reduced everybody's antibiotic doses, well, that might not actually be the right thing to do. It may be that we were giving the right dose of antibiotics just to the wrong number. And so you've got to understand any changes that you make and do them very carefully, incrementally. But overall, I think we just need to have a better synthesis of patients' kidney health on a day-to-day basis in the ICU, whether it's improving or deteriorating, and those who need perhaps more detailed investigations.
I couldn't agree more. And I think one of the good things about detecting kidney dysfunction early in our critical care population is that we could try and plan interventions that might turn kidney function better and around, and also have a better understanding of what's causing it to be dysfunctional in the first place. Because sometimes it's not the kidney's fault, it might be other organs that are dysfunctional, and us only focusing on the kidney might mean that we've got a better number, but they may not be better overall for it. So it's one really important organ in a whole system that we have to keep our focus on.
And I couldn't agree more there. And I think, when we were training in renal medicine, we were often referred patients with sepsis because they had kidney problem. And in fact, their kidney problem was a bystander, and actually what the attention needed to be for the sepsis. And that may be why we went into critical care to some degree, but it's understanding the patient as a whole. And I guess that kind of brings us to talking a little bit about how we can help our colleagues in intensive care understand patients' kidney health and how to treat kidney injury better. And we've been involved in launching a intensive care nephrology pathway, because this is a broader subject than just acute kidney injury. It includes people with chronic kidney disease. It includes the role of the kidney in the normal homeostasis and how that's impaired in critical illness, and of course renal replacement therapy. And so, Barbara, I don't know if you wanted to say a few words about the intensive care nephrology pathway. You're helping lead this major initiative of the section.
Yeah, I'm delighted to do this. So we here at the AKI section of the ESICM have recently launched the intensive care nephrology pathway. This is an educational endeavor where we're hoping to improve our understanding and educational pathways for acute, not just renal replacement therapy, which we know is a really important life-saving therapy we have in the ICU, but also acute kidney injury. We are setting this up at 3 different levels, which each will have its own expert faculty. And the levels are aimed at people who are early on in their training, who don't have a huge amount of expertise in either dialysis or acute kidney injury, to people in level 2 who are a little bit further along their career, either as nurses, pharmacists, or doctors. And finally, in level 3, where we'll be doing a mentoring program, fellowship programs, to really try and develop ideas that we can implement both through our clinical practice or our research endeavors to improve how we diagnose acute kidney injury, how we treat it, and develop treatments for the future, so this is less of a burden on our critically ill patients.
Thank you very much, Barbara. So we'd very much encourage you to check out the ESICM website. We had a webinar describing in great detail the launch of the program. It's available under the news of the AKI section, and watch this space for our foundation introduction to intensive care nephrology, our transition course, which is involving more advanced content, and in the future an advanced course which will be really looking at being involved in the future of critical care nephrology from a managerial, service delivery and research kind of point of view. Thank you very much for joining me, Barbara.
And happy World Kidney Day.
Happy World Kidney Day, indeed. Thank you very much, and goodbye.